bypass with only trap ligation. It's called surgical flow alteration, which is an alternative to flow diversion, which endovascular people do. Now, this was the case of a large ICA bifurcation. Both the A1 and the MCA were coming out from the fundus. So they said they can only put a flow diverter from the ICA to the MCA, but what happens to the ACA? The ACA will get blocked. So we said, okay, this is not a good technique. So we opted for flow diversion. So we did a high flow bypass from the common carotid to the MCA, and with a venous, saphenous vein, and so that was anastomosis to the MCA, and then anastomosis is done to the carotid, and then one can see here there's a good flow from the carotid to the MCA, and then we confirm again with fluorescent dye that patency is there or not. This is again another case of ICA bifurcation. We did a flow diversion. In flow diversion, where we did a carotid clamp and did an anastomosis, and this was the post-op scan. And you can see here that this is done before discharge. You can see that how the aneurysm has shrunk in size, and so this is how the technique of flow diversion helps in aneurysms which cannot be treated with endovascular. The last technique is bypass with trap ligation. Bypass trap ligation is done when if the aneurysm is flowing retrogradely in the cross compression, the flow is very good. Then if you do flow alteration, it will not work. So one has to do trap it. So we also have to put a clip above and below. So that's what we do, trap ligation and do a bypass. In giant aneurysms, when in a cross flow, there is a retrograde flow into the aneurysms. Like, or this patient is a pica aneurysm, and they said patient came with a bleed, and then it was again not a sacral aneurysm, fusiform aneurysm, and endovascular people said that they will occlude the pica, and then we did not accept that occluding the pica is the best treatment. So we said we'll do trapping and do a bypass from occipital artery to pica. So this is a fusiform aneurysm of the pica. So we did clipping or the trapping of the aneurysm of the pica. So this is the lower cranial nerves, the vertebral artery, and the aneurysm coming out from. So we trapped it, and you can see the trapping on both sides, and checked with a Doppler. There was no flow in the fundus of aneurysm. We had to put more clips because with a Doppler there was some flow patency, so we put more clips distally to trap it adequately, and then checked with the ICG that the aneurysm was not flowing. And after that, this is another case where is another pica aneurysm where again we have done trapping, and then we have harvested the occipital artery, and we did occipital to pica bypass. So this is harvesting the occipital artery, and then occipital artery was anastomosis to the pica was done. So in conclusion, surgery, microsurgery is there to stay for future, for all the ages to come, because there are many aneurysms which cannot be treated with endovascular. So it's only as a neurosurgeon we have to learn and master appropriate technique and strategy for all aneurysms. We need not be confused that only endovascular is the only way, because both are equally complementary. Before I conclude, I'd like to invite you to the ISP, the International Pediatric Neurosurgery CME. We'll have it at Hyderabad in July 4th to 6th, as well as the National Spine Meeting in September from 19th to 22nd. Thank you for your attention.